Çok teşekkür ediyoruz hocalarımıza. Şimdiki oturumumuz The Challenge of Immature Respiratory Control Superimposed on Immature Lung konulu oturumu yapmak üzere oturum başkanları Profesör Doktor Sayın Eren Özek, Profesör Doktor Sayın Nihal Oygür'ü davet ediyorum.
Yani bu kadar güzel, sesim geliyor mu? Bu kadar güzel duygusal sözlerden sonra bana bir şey bırakmadılar. Yani söyleyecek bir şeyim kalmadı. Ama birkaç cümleyle ben de eklemeler yapmak istiyorum. Ablam, akıl hocam, Profesör Doktor Nilgün Kültürsay'ın emeklilik töreninde böyle bir görevi almak benim için büyük bir onur. Aslında çok fazla söylenecek bir şey gerçekten kalmadı ama Türkiye'de neonatolojinin bilim dalı olarak kabul edilmesinden önce başlayıp bugünlere kadar hepimiz çok uğraştık. Çok emek çektik. Ama Nilgün abla hep bizim birkaç basamak önümüzde gitti. Bize yol gösterdi, yardımcı oldu. Ondan çok şey öğrendik. Artık dinlenme zamanı, piyano çalma zamanı, resim yapma zamanı. Nilgün abla bundan sonra mutlu, uzun, sağlıklı bir emeklilik dönemi diliyorum sana. Biz de arkandan geliyoruz. Sen ne yaparsan biz de onu yapacağız. Onun için seni takip edeceğiz. Evet, buna hazırız. Bu son konuşma Profesör Doktor Richard Martin'e ait. Aslında Richard Martin'i biliyorum. Nilgün abla ile birlikte bir süre Ohio'da, Cleveland'da çalıştıklarını. Sizlere ufak bir davet öncesi tanıtım yapmak istemiştim ama gördüğüm kadarıyla hepimiz Richard Martin'i çok iyi biliyoruz. Yani burada kalanlar. O nedenle ayrı bir tanıtıma gerek yok. Vakit kaybetmeyelim ve Doktor Martin'i de bekletmeyelim diye düşünüyorum. Ancak Profesör Martin'i size bağlamadan önce benim eş başkanım Profesör Doktor Eren Özek de bir şeyler söylemek istedi. Eren, bağlandın mı?
Evet, bağlandım. Duyuyor musunuz sesini acaba?
Girişi, evet duyuyoruz seni. Girişi ben yaptıktan sonra Profesör Martin'i davet ettikten sonra kapanışı senden rica edeceğim. Böyle anlaşmıştık zaten. Şimdi sözü sana bırakıyorum.
Tabii ki. Öncelikle bu toplantıya katılmaktan onur duyduğumu belirtmek isterim ve Ege Üniversitesi Yeni Doğan Bilim Dalı'ndaki arkadaşlarıma ve Nilgün hocamıza davetlerinden dolayı teşekkür ediyorum. Profesör Nilgün Kültürsay, Türkiye'deki Yeni Doğan camiasında imzası olan büyük hocalarımızdan bir tanesi. Eskiden kariyerimin başında büyük hoca dendiğinde açıkçası fazla bir anlam veremezdim. Ve abilerimiz bak ama o büyük hocaydı dediği zaman. Ama yaşım ilerledikçe, kariyer basamaklarına çıktıkça gerçekten büyük hocanın sadece bir akademik dosya veya ünvanın çok ötesinde bir şeyler olduğunu anladım. Büyük hoca dediğimiz zaman mentörlüğü barındırıyor. Gençlerin yolunu açmayı, onlara yeni ufuklar açmayı, daima yol gösterici olmayı, sığınacak bir liman olmayı ve her durumda bizim bakış açımızı etkileyecek ve söylenecek bir sözü olmayı, daha bunun gibi birçok şeyi. Eğer bütün bunları birleştirecek olursak ve bütün günkü konuşmaları da birleştirecek olursak, Profesör Nilgün Kültürsay gerçekten büyük bir hocaydı ve kendisini saygıyla selamlıyorum.
Hi, this is Richard. Should I start now?
Good morning, Professor Richard Martin. I think it's morning time in your country. Am I true?
It is morning, it is 9:15, and I'm thrilled
We are-
to be here. I just want to check with you. Can you hear me and can you see my first slide?
Yes, we can hear you very well. We are in the evening time and in the symposium organized for the retiring ceremony of Professor Nilgün Kültürsay. As far as I know, she worked with you for some time in Ohio. Am I right?
Oh, that is correct. In fact, Nilgün introduced me to the world of Turkish neonatology. And it's been a wonderful experience, and I have met amazing people, and I am extremely grateful to her for having done that. I wonder if I could just go to my next slide. Can you see this slide?
Yes, very clear.
I think it's a wonderful slide. This was in Antalya in 2014, as I think you can see. And it looks like a celebration. And obviously today is a celebration. And I'm not quite sure why I was given these flowers, because obviously because I was there, I guess. I actually, my memory of Antalya is a wonderful meeting and the most amazing dance party after the meeting. And I hope you haven't forgotten how to celebrate like you celebrated so nicely many years ago. So what I would like to do now, if it's okay with the group, and thank you for your kind words, Eren, which I didn't understand, but I'm sure they were nice. I would like to spend maybe 30 minutes to talk a little bit about the subject, which is the challenge of immature respiratory control superimposed on a preterm lung. It's like the premature babies we take care of have two disadvantages. The lung is immature and they don't always want to breathe. And I'm going to spend my time discussing briefly these 5 things. Where have we been? A little history, the challenge of ongoing respiratory morbidity in our population, which is real, linking immature respiratory control and respiratory morbidity. What are some underlying mechanisms that are being explored? And is caffeine the answer? And my introduction to neonatology was in the early to mid 1970s. And I got 2 pieces of advice at that time. The first was a solution for prematurity is at hand, and to get into neonatology is a risky move. Well, that proved to be wrong, sadly. The other advice I got was that all the respiratory problems have been solved. And if you're going to have to do research in neonatology, avoid the lung. And the reason for being told that was really 2 things. The first was that it was recognized that surfactant deficiency was the cause of what we refer to then as hyaline membrane disease. And nobody was ever going to be able to do very much about that. And the other reason for avoiding respiratory research was that the solution for respiratory distress syndrome had arrived. We had now available since 1971 and the work of George Gregory, the ability to give CPAP to babies, which improved their lung volume. And that was clearly the definitive treatment for RDS. About the same time, when I joined Cleveland, my major mentor was Marshall Klaus, who was one of the pioneers of neonatology. He died a few years ago. And he was one of the first to document that apnea is a common problem in premature infants, and made this statement in 1969, which I think is interesting. Continuous monitoring of respiration in small infants is now clinically feasible. I mean, we can't imagine not monitoring respiration or heart rate for that matter in our infants. And there was a time when this was a relatively new innovation. So I devoted my research career to studying apnea. Well, it wasn't the lung, right? It was about the brain. Unfortunately, I realized pretty quickly that the lung and the brain and respiratory control work together. Let me just digress for a moment and talk a little bit about the challenge of ongoing respiratory morbidity in our patients. Now, in 1967, Dr. Bill Northway coined the term bronchopulmonary dysplasia, which has stuck with us to this day. Of course, this was a different time. These were bigger babies. They were ventilated in very different ways to what we do today. And the problem continues. we are really still grappling with this a lot. And I think there are several challenges. One of them is that the pathophysiology is so diverse. We have an alveolar problem. We have a pulmonary vascular problem. The two are probably interrelated. And we have an airway problem. The airway problem, which I'm going to say a few words about, doesn't sort of manifest in the NICU because bronchodilators in the NICU are not very successful. And yet there is this large population of premature infants who are wheezing later on. It's as if I was at a meeting where Dr. Baraldi, who's a good neonate, who's a good pediatric pulmonary researcher from Padua in Italy, was saying, it's almost like an alveolar problem. And I don't know whether you can see, can you see my pointer or not really? Yes, it's as if an alveolar problem in the NICU has become an airway problem later in life. And we don't really understand that very well. The other challenges are here, that the incidence in extremely low birth weight infants of BPD approaches 40%, which is very high. Sometimes it's less, but it's often not much less. We don't have a good definition. A lot of people are struggling with that. Animal models remain a challenge. And of course, there is this strong relationship, which we also don't understand that well, between BPD and neurodevelopmental disability. Here you see what I mean. This is some Dutch data looking at the association between BPD and IQ deficit. On the horizontal axis, you see the increasing incidence of bronchopulmonary dysplasia. And a big circle is a big study, and a little circle is a little study. So I thought this was sort of quite a nice way to present this. This is a measure of IQ. So the more negative you get here, the worse, the greater the developmental disability. And you can see as the incidence of BPD goes up, the incidence of a poor IQ also goes up. What's that all about? It's probably multifactorial. We have a lot to learn. This is something that I've taken a considerable interest in recently, and I think we really probably need to focus less on the definition of BPD, which we can't really define very well, and focus more on the longer-term respiratory morbidity of preterm infants. There are many data like this. This is relatively recent data, although this story really goes back several decades. Looking at the respiratory outcomes, for example, in survivors of extreme prematurity at 19 years of age. FEV1, for those of you who don't remember your respiratory physiology, is the amount of air exhaled in 1 second with a forced expiration, a measure of airway obstruction, okay? And here you see a z-score, so -2 reflects 2 standard deviations below the mean. So you can see the term babies are at a 0, that's fine. The BPDers are in the worst shape. They're about 2 standard deviations below the mean in terms of their airway function. But this group is also a worry. 1 standard, now there's not so many, there's the same number of patients here, but this is a much bigger group of infants. This is 30 weekers and 32 weekers who don't develop BPD. They also have significant impairment of airway function. We need to understand this better and caution our families. This is, I think, quite an interesting slide, which shows the trajectories of lung function in infants and children. And at about 25 years of age, we are told that respiratory function peaks, is at its top. Unfortunately, most of us sitting in this room, listening to this video, certainly myself, are more than 25 years old. In fact, I am much older. I think I'm 3 times old. My age is 3 times 25. So I'm obviously on this decline. If you're a smoker, it's obviously much worse. But our preemies are at about 85% of lung function. So I think we need to be a little bit concerned as our preemies age. What potential risk factors do they have for chronic obstructive pulmonary disease and other problems? So now a word of caution. Now I just want to say a few words about linking immature respiratory control and respiratory morbidity. And I was being blessed with many wonderful fellows. Here are 2 of them, Wally Carlo, who has made a great career at the University of Alabama, and Estelle Gouda, who is now the head of neonatology at the Hospital for Sick Kids in Toronto. both wonderful institutions. And here you see a technique known as respiratory inductance plethysmography. So it's better than impedance monitoring, which is, it measures abdominal motion here. Obviously upward is the diaphragm. Here's the rib cage. And here's a semi-quantitative sum of the two. So you can see here, this baby has no effective ventilation. He or she has a short pause in breathing. And then you have these obstructed inspiratory efforts. They're small, but they're enough that the impedance monitor we have on the infant would not recognize that there's a problem, because we don't have this. We don't know that there's no airflow, and the impedance monitor would think this baby is breathing. Fortunately, we have a heart rate monitor, and even more importantly, we have a pulse oximeter. And you can see this pulse oximeter, which is in the mid-90s, is falling to 67. I think the most important thing about this slide is a 10-second pause in breathing is causing a significant fall in oxygen saturation. If we hold our breath for 10 seconds or 20 seconds or 30 seconds, and put a pulse oximeter on, we're not going to get this sort of response. So there is very little reserve in these infants. You have a combination, as you see here. You've got immature respiratory control. You've got compromised lungs and airways with little reserve, potentially a component of pulmonary hypertension, and obviously aggravated by a low baseline oxygenation. If we start at an oxygen saturation at 87 and we pause in our breathing, we are going to have a much more significant desaturation or intermittent hypoxic episode, which is pretty obvious, I guess. Do these intermittent hypoxic episodes contribute to possible adverse neurorespiratory outcome? This line is in dots, is hatched, because we don't quite know, but we need to figure this out. I want to show this slide because I think this is very interesting. This is one of my junior faculty members, Tommy Raffay, who's doing very nicely. He looked at the incidence or the number of intermittent hypoxic episodes per day, and there's many of them, in infants who were destined to and not going to get BPD, starting in the first week of life. Now, what we've known from the work of Julie DeFiore, my research engineer for many years, for reasons, again, we don't understand very well, the incidence of desaturation episodes is not so great in the first week or two. It sort of peaks and then starts to decline. It sort of peaks at around 2 weeks, and then, of course, starts to decline. And in this group of infants, starting at around 10 days of age, the infants who were going to be defined as BPD, obviously later, started having significant more episodes of intermittent hypoxia. This has been shown also by a group at University of Virginia, and there is a paper I don't have a slide of this, there is a paper in the Journal of Pediatrics from Eric Jensen at CHOP, showing actually that the incidence of intermittent hypoxia separates the BPDs and the non-BPDs even earlier than the 2 weeks, 10 days shown here. What does this mean? Well, I think if you remember one slide from all this, it might be this one. There's several possibilities. One is that the intermittent hypoxic episodes, or the DSATs, are actually themselves an oxidant stress, which can be pro-inflammatory. There's a lot of literature on that, although not in neonates, more in animals, that in turn may aggravate neurorespiratory morbidity. It may just be a confounder. It may be that there are pre- and postnatal precursors, such as chorioamnionitis or sepsis, which may cause these babies to have desaturation episodes, may cause these infants to subsequently develop BPD, and the two are not necessarily related. The third possibility is that it's what we do for these intermittent hypoxic episodes that may be a contributor. If you have desaturations, we may give you oxygen, we may increase your ventilatory support, so it may actually be the intermittent hypoxia is modified by what we do to contribute to respiratory morbidity. This is a figure we put together in a review for, this stands for seminars in fetal and neonatal medicine, I think. Fairly recently, Steve Conlon was one of our fellows. So what are some of the underlying mechanisms that are going on here? Well, in the world of adult pulmonology, they're sort of ahead of us here. There's been a literature for many years now that intermittent hypoxia and the reoxygenation that occurs is both an oxidative stress and pro-inflammatory. Now, what do I mean by reoxygenation? Well, obviously, we can treat a desaturation episodes by increasing the supplemental oxygen we give. We'd rather not do that. But actually, even falling down to 67%, say, the recovery to 95, actually even spontaneously, right, could conceivably be some sort of an oxidant stress. Now, adult pulmonologists are mainly interested in this because of the problem of adults and also pediatric sleep apnea. Intermittent hypoxic episodes in sleep apneic patients have been associated with cardiovascular disease and other longer-term respiratory morbidities. And there are data such as this out there, which have been around for a while. Here you see a pro-inflammatory cytokine on the vertical axis. Here you see some control adults. Here you see adults that have obstructive sleep apnea with a higher serum level of TNF-alpha. And when their obstructive sleep apnea is actually treated with CPAP, which is the standard treatment for that, the pro-inflammatory markers go down. We do not have, we're trying to collect some right now. We're working on it, but we don't have data like this in neonates. So it may be that we've got antenatal inflammation in the form of chorioamnionitis, postnatal sepsis, both bad events, which may be pro-inflammatory. There's also evidence that pro-inflammatory response via both in the lungs, because obviously the lung is exposed to the adverse effects of chorioamnionitis in utero. There can be both systemic and neural mechanisms that may impact adversely immature respiratory control. This has been work we did many years ago in neonatal rodent models, which in turn can lead to apnea, intermittent hypoxia. And you can see how this can be sort of a feed-forward self-propagating system. So in fact, it may well be that immature respiratory control, intermittent hypoxia, reoxygenation, pro-inflammatory, in turn impacting immature, in turn adversely impacting respiratory control. And you can see this can go around. Now, people have used rodent models, and I'm just going to show just a couple of studies here, rodent models to try and explore this. This is a collaborative group. I think this was done out of the Hospital for Sick Kids in Toronto. They looked at the effect on respiratory morbidity of intermittent hypoxia during recovery from neonatal hyperoxic lung injury, causing long-term impairment of lung development. So the model is really, if you take a neonatal rodent and expose them to supplemental oxygen, it has been used widely, as many of you probably know, for a model of BPD. So you do that. In this case, they did for 2 weeks, which I think is probably too long, and I think the oxygen is too high, but this can be obviously modified. Then they allowed the neonatal rodents to grow up, to be adults. And during that period, they were exposed either to room air or to intermittent hypoxia. So it was lung injury induced by hyperoxia, followed by intermittent hypoxia. And I'm just going to summarize this to say, probably doesn't reflect so well on this slide. This was the worst, these were the worst lungs, okay? These were the lungs that were exposed in the neonatal rodents to hyperoxia and subsequently had intermittent hypoxia. And this is a measure of lung development, which is secondary CREST, which is the lowest number in this group. So maybe there is a confounding effect here. And then there are these data from a number of years ago from a group at Columbia in New York, looking now at brain development rather than lung development. Similar kind of protocol, the contribution of intermittent hypoxia to late neurologic handicap in hyperoxia exposed lung injury. So you've got a hyperoxia exposed lung, inducing lung injury, subsequent intermittent hypoxia, and their data suggest that intermittent hypoxia associated with hyperoxia-induced lung injury, not that just the lung injury resulted in the worst neurologic outcome in these neonatal rodents. So maybe it's what we would describe sort of in slang, a sort of a double whammy kind of effect. Here you see some work from one of my former fellows, Andy Dilag, who's now in Rochester, New York, and he looked at the effect on the lung and he had looked at the effect of intermittent hypoxia with a subsequent and hyperoxia on respiratory system resistance in neonatal mice. And here you see respiratory system resistance. Here you see response of lung resistance or respiratory resistance to a cholinergic agonist, which induces contraction. And the group that really did the worst, who had the neonatal rodents who were now 3 weeks old, I think, who did the worst, were those that had the combination, as you see here, of intermittent hypoxia and hyperoxia. So there are potential both respiratory and neurodevelopmental disadvantages. We're working with a colleague of mine and a good friend of you guys as well, I'm sure, Max Vento in Valencia in Spain, who's done some of the pioneer work looking at oxidant markers in infants. And we've actually, we're looking at the data right now. We've collected in about 150 babies as part of a study, the number of intermittent hypoxic episodes at 2 postnatal periods. We've collected blood and urine, and we're going to try and see if we can measure some of these pro-oxidants and relate them to potential injury in different areas of the developing infant. And this is a study, this is part of a study which has just been refunded. It's called the PREVENT study. This was driven by the fact that the folks at the NIH decided a few years ago, you know, the problem of longer-term respiratory morbidity, what's the contributor of immature respiratory control? And this is a multi-center observational study where we are looking at mechanisms of ventilatory control that contribute to later respiratory morbidity. The centers involved, as you see down below, and our center is focused mainly on the oxidant-related pathways. I'm just going to conclude with about 2 or 3 minutes talking about caffeine. Is caffeine the answer to these problems? We know from a review of nearly a decade ago that the only treatments that have reduced the incidence of BPD without serious adverse events have been caffeine and vitamin A. And I'm not going to talk about vitamin A because most people probably don't use it. It's not very practical. We have a lot of choices. Turkish coffee is obviously one of them, right? You guys have quite an interesting coffee culture, and there are many ways to give caffeine, as you see here, and we are still learning. It's interesting to me that it was in the early part of my career, in the mid 1970s, where these data were published, that both theophylline and caffeine were significantly able to reduce apnea. And I remember the next 20 years where people were a little concerned, well, you know, xanthines inhibit phosphodiesterase, which might be important, increasing cyclic AMP. Could we be doing some harm? And we sort of were using it cautiously. And of course, Barbara Schmidt came along and wrote this lovely editorial, Methylxanthine Therapy in Premature Infants, Sound Practice Disaster or Fruitless Byway. And I remember reviewing her grant for the Canadian Institutes of Health Research, and her hypothesis, which she believed, she was worried. She believed that caffeine could have adverse effects on longer-term outcome of our high-risk infants. Fortunately, she was wrong. And it's always nice when you're wrong, especially with a good outcome. And as you all know, she showed that the caffeine group got extubated about a week earlier. They got off oxygen about a week and a half earlier. They had all sorts of benefits at 18 months in terms of cerebral palsy, poor developmental outcome, retinopathy, and so forth. They seemed, according to the work of Lex Doyle from Melbourne, as they grew up, to have a lower rate of developmental coordination disorder, which is, of course, probably more important and more than the few. We have cerebral palsy, obviously, but this has become, I think, for the follow-up people, and there may well be someone in the audience who can correct me on this, I think looking at some of these developmental coordination disorders in our former preterm infants is probably at this stage much more important than the smaller number who have cerebral palsy. And this is probably, I think, the last word on the subject, that at 11 years of age, the caffeine-treated infants had improved motor outcomes. I don't think this was hypothesized. And I think when I've spoken to a few people like Terry Inder, who understand this sort of outcomes work better, I don't think they would have hypothesized that a longer-term benefit of caffeine would be on the motor side rather than on the academic side. But that's what the data show. So we're left with a question, when to start, when to end, how much. We know that caffeine, and also some mechanistic issues, we know that caffeine inhibits adenosine receptors, of which there are several subtypes. By inhibiting adenosine receptors, it increases respiratory drive, and probably by increasing respiratory drive may improve neuromotor outcome. There's also a story, and Özge, who was in Cleveland, really did some pioneer work on this, showing that caffeine also has an anti-inflammatory effect, as you see here. And Özge's work has really led to several studies that are now looking at whether inhibition of adenosine receptor subtypes, for example, the A2A receptor, can have an anti-inflammatory effect. In other words, the stimulation of inflammation by adenosine would be blocked. And it makes sense that there may be an anti-inflammatory effect, which could obviously benefit outcomes. So I must say thank you for Nilgün. Thank you, Nilgün, for sending Özge our way to Cleveland quite a few years ago. I think she made a very nice contribution. So what are we left with? When should we start the caffeine? How early should we start? There's various data, which I think you're familiar with, since the CAP study, that people have tried starting earlier than the Schmidt study ever did. And there's some data that say that earlier onset improves various morbidities. However, just about all those data are an association. They're not randomized trials. For example, you may decide you're going to withhold the caffeine for a few days because this baby's not doing well. And so there are several biases that can obviously be imposed on association. And then there are some data from Holland that you may have seen, from the Netherlands, that some people are suggesting maybe we should give it in the delivery room. I think that's premature to think about, but earlier, how early is too early? I don't know. Then there's the question of how long should you give it? There are data that say that if you give it longer, you'll decrease the duration of intermittent hypoxic episodes, which may or may not be bad. If you give it longer, you may shorten the hospitalization if you're prepared to send the baby home on caffeine, which I'm not sure we necessarily are. It's going to prolong the hospitalization if you give it longer, if you're going to want to get the kid off caffeine before you send the baby home. I think both of these are probably fairly safe approaches. The one that bothers me, I think, is the most is when people start getting into very high doses. A higher dose may strongly enhance respiratory neural output. However, adenosine receptor inhibition of inflammation is variable and dose dependent. There is a preliminary report, although I don't think it's been subsequently substantiated, of high doses causing cerebral injury. So I think while many of us probably go to maintenance doses, and I think it's I think normally we would do a maintenance of about 5. I think some go up to 10. I'd be very, very reserved about some of the recommendations which say to go above a maintenance dose of about 10. I don't think we quite know what we're doing when we do that. And I think at that point, I'd like to end. I think I had half an hour, and I hope I haven't gone over. I want to thank many people besides Nilgün and besides Özge for some wonderful experiences. This is my current lab. Kathy Mayer runs the lab. Pete McFarlane is PhD. Tommy Raffaele I've mentioned. Julie DiFiore is a research engineer. You're probably aware of her publications. Worked with me for nearly 30 years. Anna Maria Hibbs is a faculty member, and Prakash is my colleague at Mayo. Whoops. So I just want to say that I am absolutely thrilled to have been invited to do this. I will get nervous about sharing screens, but I think it sort of worked. It's wonderful to see old friends, and I'm not sure what Nilgün is going to do. I remember visiting at the meeting. I've been, I think, twice. One was the meeting in Chesme, I think, and one was the meeting in Antalya. They were both wonderful. And I think at one of the meetings, I think the Chesme meeting, I got to see Nilgün's I think it was a summer house near a beach, and she gave us that. I remember a neighbor gave us coffee or tea or something. It was wonderful. So I don't know how much time you're going to spend with if I guess it's a beach house, if I were to call it that. I'm sure you will be kept very busy, and thank you for your contributions to neonatology. And thank you all very much for your attention.
Thank you, Richard, for this state-of-art lecture. And I open the talk for